Okay, thanks, Sean, for the introduction. Yeah, I'm a professor of neurology at the University of Calgary with interest in small vessel disease of the brain. Most of my research is on chronic small vessel disease as a cause of cognitive decline and cerebral amyloid angiopathy as a particular cause. But we decided today I'm going to share what I know about acute small vessel disease, acute lacunar stroke. And it's a pleasure to address you today. Lots of connections between Calgary and Texas. We're both conservative for our countries, oil and gas producing regions. And the head of my program, Andrew Demchuk, was a fellow with Jim Grata, back in the early days, the exciting days. The beginning of the more exciting days, I guess you could say, in acute stroke treatment. So lots of connections there. These are my disclosures. So I have grant funding from Canadian sources to do research projects. I do MRI analyses of images for these two universities, as well as a couple of companies. I get some royalties for writing a chapter on vascular cognitive impairment for Up to Date. And I'm the deputy editor of Stroke, so the American Heart Association sponsors some of my salary, which is paid to the University of Calgary. None of these disclosures are that relevant to the topic. I will discuss non-FDA approved investigational therapies for early neurological deterioration after acute lacunar stroke. Here's a picture of my research group from Christmas and the funding agencies that have funded my work. So I'm going to review definitions and classification of both chronic and acute lacunes, talk about the pathology, like the seminal studies by C. Miller Fisher, clinical radiological syndromes very briefly. I'll spend some more time on the capsular warning syndrome, fluctuating lacunar symptoms, and early neurologic deterioration, because this is one of the most difficult and frustrating aspects of clinical care of these patients. And then very briefly discuss the potential that genetics could give us some more insight into pathophysiology that may give us new ideas about prevention and treatment. Okay, so lacunes were first recognized more than 150 years ago at autopsy as small CSF-filled cavities. And there was for many years, a lot of debate about what the origin of these lesions were, with theories, predominant theories, including that they were related to vasodilation and constriction of the vessels. Miller-Fisher's work really clarified that these are forms of stroke. And so a lacune then refers to the finding of a CSF-filled cavity, and the most likely recognized today on neuroimaging. A lacunar infarct would be a lacune that originated as infarction. And even today, there's still some debate about whether all lacunes are caused by infarction or not, although it seems likely that the majority are. And finally, lacunar stroke would be a lacunar infarct that's associated with the clinical symptoms of a stroke syndrome. So I'm going to try to be precise in my terminology moving forward. As I said, C. Miller Fisher, defined the pathology of the modern understanding of the pathology of lacunes. I had the privilege to work with him when I was a neurology resident at Mass General in the late 90s and early 2000s. He was still doing his C. Miller Fisher rounds, so we would present a case to him once a week, and he also attended brain cutting because he used neuropathology in much of his research work. So I'd get to see him a couple times a week and present some cases to him. There's a photo of him on the left. This is a painting of him that would hang in the library at Mass General, which was also where we would present cases to Dr. Fisher. So we would be presenting a case to Dr. Fisher while in the background was a painting of Dr. Fisher. So it was a very kind of meta experience, a little intimidating at times. He was a very precise kind of patrician fellow, but really marked by extremely careful observation, both clinically and neuropathologically. And he had kind of infinite patience really to look into the details of a case. And that was really his scientific strength. And what he contributed that hadn't been done earlier were serial sections of the arteries around lacunes. Serial section meaning they would slice them with a microtome. Each section would be about 10 microns thick. That's the diameter of a red blood cell. And he would look at like hundreds or thousands of these sections to follow the vessel along to understand the relationship of the arterial pathology to the lacune. So he started with his paper in 1968. He had 4 cases with a lot of lacunes. So the 1968, effective oral antihypertensives only entered practice in the 60s. So there were like many, many patients back then with Binswanger syndrome, right, where they would have multiple lacunes and white matter damage from decades of uncontrolled hypertension. So you could find individual cases like this with, a dozen or 2 dozen lacunes. And he identified arterial abnormalities in 45 out of the 50 cases with lacunes. So this excluded that, a functional problem like vasodilation or constriction or some sort of other brain tissue problem was leading to lacunes. Like he clearly indicated there's an association with arterial pathology. In 40, they had what he described as segmental arterial disorganization. 2 had microaneurysms with thrombosis in them, so suggesting thrombosis was a mechanism to prevent lacunes or treat them. 3 had some intimal foam cell accumulation. So we know the term lipohyalinosis was used later to describe the fact that in these small vessels you would see thickening, and you wouldn't see atheroma, with like you would see in a larger artery like the carotid, but you could see lipid staining in the wall or sometimes some of these foam cells in the wall, but without the structure of an atherosclerotic plaque per se. This is an example of the segmental arterial disorganization. So on the left, you see dark staining. So there's a fibrinoid staining in the vessel wall. There's areas of necrosis in the vessel wall. It's markedly thickened. It's also disorganized. You don't really see the elements of the elastic lamina and the media anymore. On the right, again, you see the segmental enlargement. So there's kind of like a proliferation of the artery as well, as shown there. And then in his papers, he has these nice schematic diagrams, right? So he diagrams that in this case, he was looking at a pontine lacune. So here's the lacune. There's the basilar artery. There are perforating arteries in the pons. And in one of them, he sees this area of segmental occlusion with an retrograde and anterograde occlusion, and then an infarct in the perfusion territory of that vessel. So he really identified that it was vessel occlusion that was leading to lacunes. In another paper, 10 years later, I've got cut off some of my print with my picture there, but he looked at another 9 cases with 11 lacunes, this time focusing on the basal ganglia and the lenticular striate arteries particularly. And in this case, he saw in a number of cases that there was atheromatous plaque with stenosis or superimposed thrombus, including, if you look at some of these cases here, I'll turn my head to look at my larger screen, but you can see like in case 5, for example, that there was atheromatous plaque like right at the origin of this artery. And as well in cases 2 and 4, there was occlusion right at the origin of the lenticular striate where it's coming off the MCA. So this is the first pathological description of what we would now call branch atheromatous disease, where the small vessel occlusion is not during the course of the artery in the brain substance, but rather the vessel's occluded at the origin where it's coming off the parent artery and sometimes associated with a atherosclerotic plaque. So implicating the pathophysiology of atherothrombosis potentially with the cause of lacunes. Okay, and then to be honest, after those 2 papers, there hasn't been that much more neuropathological work. No one else has the patience to really do these serial sections like Miller-Fisher did. So a lot of our work now is trying to develop neuroimaging correlates of the pathological features. Challenging because the small arteries that are occluded in lacunes, tend to be between 100 to 400 microns in size. And the size of a typical MRI voxel would be about 0.9375 millimeters. So each voxel is about twice as big as the diameter of the vessel. So they're hard to image. With 7T imaging, so high Tesla imaging, we can begin to see the larger lenticular striates. You can see some of the larger lenticular striates on CTA as well sometimes. So, but for the most part, when we're using neuroimaging, we're not imaging the vessels themselves, we're imaging the tissue consequences of their occlusion. So the radiological definition of a lacune was defined by the STRIVE group, which is a multi-country, multidisciplinary initiative that I co-led along with Joanna Wardlaw and Martin Ditchkins. And There was a lot of heterogeneity in how lacunes were described in the literature, and so we wanted to standardize the terminology and also provide a specific radiological definition, which we did as following. So we call a lacune of presumed vascular origin. So one of the principles behind STRIVE was to describe what you see, not what you think you see or how you thought it originated. We are acknowledging that the vascular origin is presumed, and that we are defining the radiologic characteristics of a small fluid-filled cavity, essentially. So a round or ovoid subcortical fluid-filled cavity between 3 to 15 millimeter in diameter. That's when they're chronic. In the acute lacunar infarct can be somewhat bigger than 15 millimeters in axial diameter. And it's compatible with a previous acute small deep brain infarct or hemorrhage in the territory of a perforating arteriole. It's often but not always surrounded by an area of hyperintensity on FLAIR imaging corresponding to peri-infarct gliosis. And it has to be discriminated from other small spots. So you discriminate it from white matter hypertensities by the fact that lacunes have a central CSF-like signal. And you distinguish them from perivascular spaces by virtue of they're typically larger. Most perivascular spaces are less than 3 millimeter diameter. And also by the shape. The perivascular spaces are long tubes, following the course of the perforating arteries, whereas the infarcts have more of a, well, they have complicated shapes, but they're more of an ellipsoid or sort of mildly conical type shape, not a long tube like it's following the course of an artery. And there's limited neuropathological correlation data with lacunes, but the data we have suggests that this radiological appearance is relatively specific for lacunar infarction, with a postmotor MRI study showing that if you apply a STRIVE-like criteria for lacunes, it's 96% sensitive and 91% specific, with the main false positives being due to perivascular spaces that appeared more similar to a lacune. Now, of course, in the chronic stage, we see a lacune after, a prior event and the tissue is melted away and we have a CSF-filled cavity. We can't tell how that lesion originated. And in fact, small vessel lesions can be quite dynamic in terms of how they originate or evolve. So we understand now, actually, that about 30% of small subcortical infarcts don't turn into a lacune, actually. They turn into either a white matter hyperintensity, or often it's even inapparent when you image the patient later. So that has to be kept in mind when thinking about the fact that the chronic lacunes we see in someone's brain may be only a subset of all the prior acute events they've had. Some of them may have happened and then disappeared into the background, or be visible only neuropathologically as a microinfarct. Okay, the best paper, I think, on the clinical correlations of acute lacunar infarcts is also by Miller-Fisher, and also an older paper, but it's based on very careful clinical examination of these patients. And there are quite a few syndromes listed here, and so quite a variety of findings can result from lacunar infarction. The most common, though, and the ones that I would ask a medical student and neurology resident to be well aware of and be able to recognize clinically, would be pure sensory stroke. So that's where you have unilateral sensory loss or anesthesia caused by a contralateral lateral thalamic acute lacunar infarct. The pure motor hemiparesis syndrome, where you have paresis of the face, arm, and leg, and that would be due to a contralateral infarct in the corticospinal tract, usually in the posterior limb of the internal capsule or the corona radiata, sometimes in the pons. The ataxic hemiparesis syndrome, where you have usually milder hemiparesis, also with ataxia and often the contralateral pons or corona radiata. And then the dysarthria clumsy hand syndrome, where you have hand paresis and dysarthria. When you have these syndromes and you have an absence of cortical signs of aphasia neglect, that often points you to a subcortical location. Although data from the ECAS studies suggest that these clinical signs and symptoms are not, they don't have high diagnostic accuracy, and there can be false positives where it looks like a lacoon but turns out to be a parietal infarct, according to a CT study in ECAS from the ECAS trial. There's a whole host of other syndromes there too, which you can read if you can expand your screen. And some of them, sometimes you can get cortical signs with a lacoon as well if the small vessel infarct's involving the thalamus, right? Because, for example, you can have acute small vessel occlusion and lacunar infarction in the anterior thalamus that presents with a purely amnestic memory syndrome, for instance, kind of acute dementia. Or you can have thalamic syndromes that include neglect or aphasia because the thalamus is communicating widely with prefrontal cortex, and thalamic lesions are known to cause cortical signs, right? So the absence of cortical signs is not completely specific, but is certainly a clue that you may be dealing with a lacunar syndrome. Now, I think of lacoons as in many different buckets with different clinical and radiological and pathological syndromes. Now, I guess I'm a splitter more than a lumper. So I like to think of these different patterns, and it helps you recognize them. And some of them have different prognoses. Some of them, it's uncertain, to be honest, whether they're different than others, but based on the clinical feature, the clinical presentation, setting, or radiology, I think they might qualify as a distinct syndrome. So I kind of group them as a perforator infarct. So this would be where the occlusion is not at the branch point or at the proximal vessel, but rather within the course of the vessel, in two scenarios. One is the scenario where a patient has diffuse small vessel disease, and that can be marked by a high burden of visible white matter hypertensities would probably be the easiest way to see that, or they have multiple lacoons. And these are typically older patients with chronic cerebral small vessel disease with aging. But then I also see a group that's an isolated perforator infarct without signs of diffuse small vessel disease. And in my experience, these have been more patients in their 50s and 60s, often smokers, or sometimes diabetics. So they more have like kind of one risk factor, are not that old, and are presenting with an isolated perforator infarct without other vascular events or severe small vessel disease. Then there's the branch atheromatous disease, where you have occlusion at the origin of the vessel. And as we'll discuss later, these patients might be at higher risk for early neurological deterioration. And there may be a stronger rationale for applying anti-atherombotic risk reduction and acute treatment strategies in this branch atheromatous disease group. Then there's a rare stroke syndrome. I really see it a couple times a year in Calgary, where you have dull echoectasia with fusiform dilatation. It's usually the basilar artery, and you start to get like jailing, like perforating arteries off the basilar are starting to get picked off, and you get a lacunar infarct, sometimes a series of infarcts. When you image the basilar, you see this aneurysmal fusiform dilatation. Also, sometimes with clot. Sometimes you can see clot like filling a portion of the artery. This syndrome has a pretty poor prognosis, in my view. They often have recurrent ischemic strokes, and they are at risk for basilar perforation and subarachnoid hemorrhage as well. Then a subset of lacoons are caused by embolism. I think most people would agree. And Miller-Fisher hypothesized this was why he sometimes saw lacunar infarcts without any arteriopathology in the vessels supplying that region of the brain. There are two types of lacoons that you can see that are in close relationship to white matter hyperintensities. And this is unproven, but I wonder if some of these peri-white matter hyperintensity lacoons might be due to non-thrombotic processes. And finally, sometimes you see, in older patients, an isolated lacoon in the white matter, and this is kind of a not uncommon finding in older patients, sometimes without white matter hypertension accompanying them. So I'll show you some pictures that correlate with each of these different syndromes. So these are perforator infarcts, and by that I mean, they don't go all the way down. They don't involve the entire perforating artery territory. Sometimes there's signs of white matter hypertensity or other forms of diffuse small vessel disease, like in the panels on the left. Sometimes they can just be an isolated one, like in this patient that has a infarct in the posterior limb of the internal capsule without any other small vessel disease lesions. And as I said, with the lenticular striate arteries, we're beginning to be able to image them with 7T imaging at high field strength and with kind of time-consuming high-resolution MRA acquisitions. So this is a case where there's a perforator infarct from the literature, and you can see that this vessel here like terminates abruptly, right? So we're seeing now in vivo, right, the correlate of what Fisher saw neuropathologically. Branch atheromatous disease can be identified with the help of CTA or vessel wall imaging. So here's a case from my practice. So there's an infarct and a lateral lenticular striate. And in this case, there's a very focal severe narrowing or near occlusive lesions in the distal MCA. This one's so focal you might even wonder if it's embolic, although we did follow-up imaging in this case and saw that the lesion was unchanged. So we think it's probably, and they had atherosclerotic risk factors, so we think it probably was atherosclerosis. And again, this is the idea behind branch atheromatous disease, and that one of the clues to identifying it, in addition to seeing irregularity or stenosis of the parent vessel, you also tend to get these larger infarcts with branch atheromatous disease, or that's a hypothesis anyway. And this Dr. O'Hara was a fellow with us from Japan, so I'll thank him for providing the slide. But so this example on the top, like the previous cases, would be where at the base of the brain you don't see infarction, then an area of DWI hyperintensity is visible later, kind of in the course of the artery. And then here's an example of what you might see with branch atheromatous disease, where you see the DW lesion, it's larger and it goes all the way down to the origin of the artery. And if you reslice this coronally, you can see exactly what it is, right? There's like an infarct basically in the whole territory of the perforator, like right from the origin. So that should make you think of branch atheromatous disease. Embolism can cause lacunes, like it has to be a small embolus to get in a small artery, but we do see it. So here's an example, and estimates from the literature suggest maybe 10% are due to embolism. So I would do an embolic workup in a patient with a lacune. By that I mean an echocardiogram and some duration of longer-term rhythm monitoring, like at least a 24-hour Holter. And we can suspect this when there are multiple simultaneous infarcts, particularly when it's a mix of cortical and subcortical infarcts. So here's a patient from my practice. They had a lacunar infarct, but also a small DWI hit in the cortex. Another reason that I think this happens, another supportive line of evidence, is in my MRI core lab work, we read MRI scans that were done as part of a randomized controlled trial of two mechanisms of cerebral protection in patients undergoing aortic arch repair. And these aortic arch repairs liberate like tons of emboli. So the very high risk of emboli to the brain, like 70% of patients undergoing the procedure have infarcts that can be identified on MRI, and a much lower percentage, but still a significant number, have symptomatic stroke. So this is a case of someone who had aortic arch repair, and you can see an acute infarct in the right caudate, so that is in the territory of a small vessel, but almost certainly due to the emboli liberated during the procedure. And then these lacunes that occur in close proximity to white matter hyperintensity can be seen in the aging brain. In this study from the Lattice cohort, which was a group of patients that were clinically diagnosed with a high white matter intensity burden, then followed over time for cognitive and functional decline. With serial imaging, they saw that when new chronic lacunes appeared in follow-up, they were more likely to be kind of in the proximity or at the border of an area of white matter hyperintensity, or that white matter hyperintensity is more likely to be adjacent to the lacune than not, right? So there was a statistical association, and the hypothesis maybe something at the edge of this white matter intensity that's causing tissue cavitation. Of course, if the hyperintensity continues to grow, then what might happen is you might have the cavity, now it's completely surrounded by the hyperintensity. And so that's something that I've seen in the core lab work that we've done, and also has been described from the Lattice study. The same phenomena has been seen in patients with CADASIL, that when the chronic new lacunes appear in the genetic monogenic small vessel condition CADASIL, they also tend to be at the border where a white matter hypertensity is. So it makes you wonder if there's some other pathophysiology going on here. Maybe there's something else about either blood-brain barrier leakage or neuroinflammation that's damaging oligos and maybe leading to loss of myelin and then axons. I mean, we don't know for sure. There was a study, however, that took patients like the patients that were in Lattice. They had high white matter hypertensity burden as part of what's called the RUN-DMC study, and they followed them over time with serial imaging, like every month. So they wanted to see how often small acute infarcts were appearing in the brains of these patients, and they found 36 DWI positive lesions among these. It was distributed among about 12 of these 54 patients. At follow-up, most of them kind of disappeared, but 4 turned into lacunes. Interestingly, 3 started as infarcts, but then turned into what appeared to be microbleeds. And of the 5 new chronic lacunes, 4 out of the 5 had a DWI lesion preceding them. So very small numbers, of course, is the problem. But based on these 5 cases anyway, it suggests that most of these lacunes that we see in the white matter probably do start with acute infarction, or at least acute cytotoxic edema as inferred from them being DWI positive. So it's not only arteriosclerotic disease or atheroma that can cause lacunes. There's one paper that suggests that cerebral amyloid angiopathy may also cause lacunes in the centrum semiovale white matter. So CAA is caused by amyloid deposition in the walls of small to medium-sized arteries in the leptomeninges and the cerebral cortex. We also see that white matter damage occurs in CAA, possibly because CAA is affecting the perforating arteries when they lead from the surface of the brain and then enter the brain at right angles to perfuse the centrum semiovale and paraventricular white matter. And in this study by the group at Mass General, they compared the frequency of centrum semiovale versus basal ganglia lacunes in patients with lobar ICH due to CAA and deep ICH due to deep perforated arteriopathy from hypertension and conventional risk factors. And they found they tended to segregate. So if you were a lobar ICH patient and you had lacunes, they were more likely to be in the centrum semiovale, whereas if you had deep ICH and you had lacunes, they were more likely to be in the basal ganglia, as shown in these 2 examples. So neuropathologically, CAA has been associated with microinfarction. So it's possible that CAA can also cause either stenosis or endothelial dysfunction that leads to thrombosis and lacunes. So we have to keep that in mind in elderly patients as well. Okay, so now I'm going to transition to the second part of the talk, where I'm going to review the acute treatment of lacunes, including this frustrating clinical syndrome of capsular warning and early neurological deterioration. So this is a phenomenon that I think all stroke neurologists, practitioners become familiar with, and it's probably the most frustrating clinical scenario that I encounter as a stroke clinician, because typical scenario would be a patient comes in, they're maybe in their 60s or 70s, they've got hypertension, diabetes, they have an episode of complete hemiplegia on the right side with dysarthria but preserved speech, so pure motor hemiparesis, and you're going to start getting the tenecteplase ready to inject, but then they improve, before your eyes, maybe even all the way. And you admit them, but then, 2 hours later, they have another episode, and this time, maybe they don't fully resolve. They get better, but they're left with, grade 4 to 5 MRC, grade strength in the arm and leg, right? And the face is a bit drooping, and they're a bit dysarthric, and you're not sure, are they too mild to treat with thrombolysis? And you're not sure, and you end up not giving it based on the results of PRISMS and Tempo 2, and then, 8 hours later, they become plegic again, right? And so you add, other antithrombotics or anticoagulants, or you raise their blood pressure or lower their blood pressure. And to be honest, it's been hard to tell whether any of these strategies really help these patients or not. So that's the kind of scenario that I'm going to talk about. I don't have answers. I'll leave some time. I'd like to hear your thoughts on like how you treat patients like this. I'll review current thinking on the frequency of this phenomenon, the different strategies that have been written about in the literature, sparse data from a few randomized controlled trials that we can maybe make some inferences from, and then have some discussions. So, and I was helped by this. I guess it's on the next slide. So, first, a few words on how common this scenario is, right? So, a population-based study out of the Oxford looked at patients with TIAs and found that the capsular warning syndrome of the type that I described was rare. It only accounted for 1.5% of all TIAs, but that the risk for it turning into a stroke was much higher than for other kinds of TIAs. So there's a 60% chance of stroke by 7 days in patients with a small vessel TIA like that. And then if you look at patients that have had acute lacunar stroke and are admitted with stroke, a cohort study found that the most common, in the patients that had early neurological deterioration, which they found in 24% of their stroke patients in this cohort, it was the patients with lacunes that accounted for the majority of the deterioration. So of the 23.9% that deteriorated with early neurological deterioration or end, 63.6% were patients with lacunes, whereas only about 25% of all their patients were lacunar, is kind of as expected. So these are the patients that are high risk for end. I was helped in preparing these slides by a very recent, nicely done systematic review and discussion of end in acute lacunar stroke, published by David Waring and colleagues in IGS that just came out this year. In fact, I think it's still in online before print and hasn't been assigned a page number yet and everything. So they took as a denominator patients who were admitted with acute lacunar stroke and then looked at the proportion that had end by various definitions, from less restrictive, like any change in the NIH stroke scale score, up to a 4-point or more change. And as you can see, mild deterioration occurs in about 22 to 24%. The more severe deterioration, like the scenario I described in my example, a bit less common, but still in 11%. So it's not common, if you consider like 25% of stroke admissions might be lacunes. A quarter of them might deteriorate, so that's around 6% or so. About 40% of the deteriorations are like severe deterioration. So now we're getting to kind of numbers like 2 to 3%. So, and this has been a barrier to understanding this syndrome better, right? So it's a stroke. It's definitely a well-defined clinical stroke syndrome. It's still this risk of severe deteriorations in only about 2 to 3% of all ischemic stroke patients. So that's that's led to the fact that most of the studies have been observational without a lot of clinical trials. So they looked at risk factors in the systematic review and they used meta-regression to analyze risk factors that were commonly assessed across multiple studies. I think they found 60 to 70 studies they reviewed, although most of them were kind of smaller sample size. So by meta-regression, they didn't find an association with infarct location, but they did find they found a trend with age, although interestingly, you're more likely to have end the younger the patient was, not the older the patient was. They found a strong association with female sex, which I was disappointed they didn't elaborate on it or discuss it in any way. So I'm curious what that means. But then they found that patients with hypertension, diabetes, and smoking were at higher risk. This is speculation, but I wonder if some of these factors might be associated with risk because they're correlates of having branch atheromatous disease. Like I can imagine that the younger patients with hypertension, diabetes, or smoking are more likely to have branch atheroma. And the other subset that would contrast with them would be like the older patients with more like age-related, hypertension-related change in the course of the small arteries. Of course, individual studies looked at many other predictors. So these are some of the predictors for N that have emerged from these studies, and includes more proximal location. As we discussed, that's a a marker, potentially a branch atheromatous disease. If the DW lesion is larger, if the stroke symptoms are worse, if you see abnormalities in the MCA or PONS on vascular imaging, you can sometimes, but not always, see these lesions on perfusion imaging with CTP or MRP. And if there's low perfusion, that was a risk for a subsequent end. And the patients with higher blood pressure, and the patients with more signs of chronic small vessel disease, such as higher white matter intensity grade, were at higher risk for end. So what can we do to prevent end? So this is where you can feel kind of helpless as a physician, because well, except for maybe 2B3A inhibitors, which we can't give on our stroke ward, and cilostazol, which is not available by prescription in Canada. And I don't know if I've used argatroban because it's not stocked very much in my hospital. I've tried most of these other strategies, and based on limited clinical experience in my cases, honestly, it's hard to tell whether any of them work. So obviously, if the patient meets criteria for thrombolysis, you should give thrombolysis. Dual antiplatelet therapy is indicated as per guidelines and the results of chance and point trials, so we would do that. The ones in bold, there are some trial data behind them, so I'm going to elaborate on these in the next few slides. So there is some data to suggest that maybe ticagrelor might be superior to clopidogrel and could be considered an option. There's some RCT data we can extrapolate on use of heparin, other factor 10A inhibitors, or the new factor 11A inhibitors that suggest to me that they're probably not the solution to intervening on end. Argatroban and cilostazol have been studied in some small RCTs in Asia. And then there are observational studies that either prospective or more commonly retrospectively look at people's experience trying to change the course of end, but without a control group. And it includes looking at 2B3A inhibitors, raising blood pressure. I don't know, maybe some of these patients are very hypertensive. Sometimes I feel like I have to lower their blood pressure. And then something we got excited about like 10 years ago, but kind of gave up on, is the idea of using IV magnesium. Okay, so I'll go through the bolded ones. So thrombolysis, well, I skipped that one there. Yeah, so there are some post hoc subgroup analyses of RCTs of thrombolysis that have grouped patients according to whether they have small vessel occlusion or not, and then looked at the effect of lysis. This includes the 1995 NNDS trial. So patients were subtyped according to presumed cause of stroke, and it was based on CT and clinical exam. So there's not a lot of MRI phenotyping, and so keep that in mind that the phenotyping may be somewhat imprecise. It was only a minority of patients had lacunar stroke. So you can see from Table 5 from the original publication, there are 51 patients who received IV TPA that were felt to have lacunes, and 30 with placebo. And you can see the proportion with favorable outcome. As you recall, the NNDS trial had kind of an innovative, like 4-part outcome. Looking at the modified Rankin scale, which subsequently has been our dominant acute stroke outcome, you can see 63% of the 51 lacunar stroke patients treated with TPA had a good outcome compared to 40% with placebo. These are small numbers, not statistically significant on their own, but they're similar, or actually slightly greater than the risk difference in the overall trial population. So you could use that to infer that there's insufficient evidence to say that outcomes in lacunar stroke are different with IV TPA. Now we have more recent data from the Wake Up trial, which was an RCT of thrombolysis or no thrombolysis in patients outside the thrombolysis window who had MRI diffusion flare mismatch. And so a subset of those patients had lacunar infarction. Again, not a lot. There were 55 in total. And their outcome in terms of increased odds of favorable outcome of 1.68 was very similar to the non-lacunar patients at 1.62. It's shown in this forest plot here, so it's really similar effect. across the lacunar and non-lacunar groups. The grotto bars here show the MRS in alteplase compared with placebo in the patients with lacunes on top and non-lacunar infarcts on the bottom. So this is more precise phenotyping based on MRI, and so also is consistent, though, with the TPA study that thrombolysis produces equivalently positive results in patients with acute lacunes as it does in patients with acute ischemic stroke of other causes. So if patients eligible, I would give thrombolysis. The challenge sometimes is that they may have a severe deficit and then they get better. So do you give thrombolysis or not? Worrying that they may recur, and then also sometimes patients may fluctuate and may be at a mild state, but then when they're outside the window, they get worse, and now you're outside the thrombolysis window. So these are some of the frustrations in practice. If the patient has mild stroke symptoms and but non-disabling, or they're outside the thrombolysis window, then dual antiplatelet therapy would be indicated. Unfortunately, there's no data on whether dual antiplatelets work better or worse in lacunes from point or chance. There was an MRI substudy of chance, and they they looked at outcomes in patients with a single infarct versus multiple infarcts. But as far as I can tell, even in the supplemental materials, they never discriminated which single infarcts were a single subcortical infarct, single small subcortical infarct, and which infarcts were a single cortical infarct. So in the end, we don't have data, and it's, it'd be nice to have good phenotyping in our stroke trials with MRI to understand response of lacunar stroke to acute therapies. An observational study of lacunar stroke patients with early neurological deterioration, in which they looked at which patients were treated with dual antiplatelet therapy versus single antiplatelet therapy, did suggest that the patients on dual had a better outcome. 68% had a lower NIH at discharge than after end, compared to only 12 out of 23 or 36% on aspirin monotherapy alone. So challenge with that, though, is there was no multivariable modeling at small numbers, and it could be confounded by other reasons why the clinician chose to use dual therapy or didn't. There is the Chance 2 trial did report outcomes according to whether there was small vessel occlusion, SVO, or not. Chance 2 was a trial done in a Chinese population. It included patients that would have been eligible for Chance, except they were tested and found to be slow metabolizers of clopidogrel, which is common genetically in the East Asian population. And so the trial randomized this population to aspirin plus ticagrelor versus aspirin plus clopidogrel. So here the comparison is ticagrelor versus clopidogrel on the background of also receiving antiplatelet therapy. And in a subgroup analysis, they found that the patients with SVO had a lower hazard for recurrent ischemic stroke and in fact, it was the findings in the small vessel occlusion patients that were driving the overall positive outcome of the trial. As you can see, the hazard ratio 0.5 was much lower for small vessel occlusion than for large artery atherosclerosis or stroke of undetermined etiology. So some suggestion maybe ticagrelor might have some effect versus clopidogrel, although the outcome in this study is recurrent stroke, though not end per se, or disability outcomes. Finally, then, another study of clopidogrel was this fairly large study done in Japan, in which they randomized 54 patients to a combination of argatroban, aspirin, and clopidogrel versus argatroban and aspirin alone. So it's triple therapy versus dual therapy with argatroban and aspirin. And they were treated with 7 days of IV argatroban. Now, this is a fairly unique practice to my knowledge in Japan. I've talked to Japanese colleagues, and they do often use this cocktail of argatroban plus aspirin plus clopidogrel for the short term in patients with a fluctuating lacunar stroke or a lacunar stroke they think is at risk for end, although it's not done in Europe or North America, really, to my knowledge. So in this pilot study of 54 patients, they were randomized if they had acute lacunar stroke within 48 hours, and the rate of end was 0 out of 27 in the triple therapy group versus 4 out of 27 in the group without clopidogrel. But there's no difference in 90-day modified rank and small numbers. So again, a very different context in which we use clopidogrel, but maybe suggests the concept that adding more antiplatelet therapy might help prevent end. Old data on like heparinoid molecules, like the trial of Orgaran, didn't show benefit in patients with presumed lacunar stroke. I also analyzed MRI scans from 2 studies of oral factor 10A or 11A inhibitors. The COMPASS trial was the trial of low-dose rivaroxaban plus aspirin versus aspirin alone in patients with cardiovascular risk. About 20% had a history of stroke, so it's not an acute stroke trial. On MRI, there was an MRI sub-study of about 700 participants, and we looked on MRI at new symptomatic but also covert infarcts, which we subtyped according to new lacunar infarct or new non-lacunar infarct. And we saw that the benefit of rivaroxaban and aspirin was greater when you looked at pooled like clinical and covert events. If you look just at new covert infarcts, the effective treatment on incident non-lacunar infarct, odds ratio 0.7, was greater than for incident covert infarcts, including lacunes. So it looks like maybe there's more effective rivaroxaban and aspirin compared to aspirin alone on incident non-lacunar infarcts, is what I'm passing on from the study. In the Pacific trial, so this was a trial of asundexian. It's part of the new class of oral factor 11A inhibitors, currently not approved by FDA for any use yet, but in trial in ischemic stroke in the Oceanic, and also milvexian, also undergoing trials. We had a similar MRI sub-study in about 1,600 people, and we looked at the effect of asundexian plus usual antiplatelet therapy versus usual antiplatelet therapy alone, and found that asundexian looked like there was a trend toward preventing incident cortical infarcts, but not incident single small subcortical infarcts. In fact, the odds ratio is even non-significantly on the wrong side of 1. Lower odds are better here. So I think probably adding heparin or 11A inhibition is probably not the answer to kind of treating end. Finally, there's a recent, not finally, a couple other slides. There was a recent study of argatroban in patients with acute ischemic stroke with end, and it randomized 628 patients to argatroban plus antiplatelet therapy versus antiplatelet therapy alone for 7 days. There's no placebo, but there was blinded endpoint assessment. About half the patients had small vessel occlusion, and overall, the trial was borderline significant. But if you look in the small vessel occlusion population, you found that 84% had a good outcome versus 75%. The P in the small vessel group alone was not significant at 0.07, and the interaction p-value was neutral, meaning we can't really say that the SVO patients sort of responded better to the drug than the patients with large artery athero. But, raises the possibility that argatroban, could potentially be a solution, although these are kind of like borderline significance. Cilostazol was studied in a trial in Japan. Fairly large trial. The methods were not great. There was no blinding of the endpoints and no placebo control. But there was a control. But they found no effect of cilostazol on risk for end in this population, which included both lacunar and non-lacunar patients. Finally, for a while, we got excited about using IV magnesium based on a post-hoc analysis of the IMAGES trial, which is an RCT of IV magnesium in 2,386 patients with stroke. The 765 patients that had presumed lacunar stroke had a better response to therapy. The interaction between magnesium treatment and lacunar stroke was 0.003, so that was significantly better outcomes in the lacunar stroke patients. And these are the Grotta bars just for the lacunar stroke patients alone, those treated with magnesium versus placebo. So the odds of having an MRS greater than 1, so odds of a poor outcome were less in the lacunar stroke patients treated with magnesium, which was given as a 4-gram bolus plus 16 milligrams over the next 24 hours, and statistically significant. However, in the subsequent FASTMAG trial, there was no difference in N between magnesium and placebo. And we tried it on some patients, and the first patient we tried it on, it seemed like it worked, and maybe they didn't get worse, but then after treating the next like 4 or 5, to be honest, half of them were getting worse, half of them were getting better, and ultimately we are not really using it anymore. Finally, the results of the future LACI-3 trial may be helpful in understanding. Now, this is a trial of preventing recurrent stroke in patients with lacunar ischemic stroke. But really, after the SBS-3 trial, is the only other large trial focused on lacunar ischemic stroke. It's a 2x2 factorial design testing isosorbide mononitrate and cilostazol. And they showed feasibility of the trial and that isosorbide mononitrate reduced the risk of recurrent stroke overall with an odds ratio that's maybe implausibly low, to be honest, but suggests some the possibility that something about nitrate treatment might help. Now, these patients were enrolled median 70 days after stroke, so this is certainly not a trial of acute stroke outcomes, but may help us understand about risk for recurrent stroke or maybe point to strategies for modifying the course of acute stroke as well. I think to save some time for discussion, I'll just kind of essentially skip this, but I'm looking forward to results of more studies of genetics and genomics to potentially point for new risk factors for lacunar ischemic stroke. So far, genetic studies have mostly confirmed knowledge of existing risk factors from conventional epidemiology linking diabetes, insulin resistance, hypertension, hyperhomocystinemia, interestingly, and smoking with risk for lacunar stroke. Such that a higher HDL and interesting higher lipoprotein A may be related to reduced risk for lacunar stroke, and failed to find association with some of these other factors shown here. So in conclusion, the arteriopathology of the basal ganglia and pontine lacunes has been described well by Fisher, but the pathology of these white matter lacunes in the centrum semivalley may be less certain. Most lacunes appear to be the consequence of infarction, although not all small infarcts turn into lacunes. I like to subdivide them into multiple syndromes that have different prognoses. And END is common frustrating problem without a clear evidence-based strategy, although I think there is some support for for giving thrombolysis if indicated and choosing dual antiplatelet therapy with ticagrelor rather than clopidogrel potentially in patients at higher risk. So I'll stop there. I'll turn it back over to the chair and happy to take questions for a few minutes.
That's great. Thank you so much, Eric. Are there questions from the group, Dr. Smith? Let's see here. How strongly would you adhere to the definition of a lacunar by size, where 15 millimeters is maximum? Some slides do show strokes larger than that.
Yeah, there's a couple points about that. I think you have to use your clinical, if you're using it, for clinical care, you have to use your clinical judgment, where you can incorporate in knowledge about, the shape of perfusion territories in the brain, rather than adhere to a strict cutoff. For research purposes, though, we try to be more precise, even to make studies comparable, even at the cost of maybe some accuracy in terms of using clinical judgment. So one point is when it's not always been clear, unfortunately, when it's been described in the literature, but when we say size, like you can measure the size in 3 different dimensions, right? Well, or in any plane, right? But it usually means in the axial plane on imaging, right? So some lacunes were quite tall, right? Like the one I showed from the branch atheromatous disease. But here we're just focused on the axial imaging. Less than 15 was the definition for a chronic lacune, but acutely they can be swollen, right? So you can see them up to, I would say, at least 20 millimeters, like larger in axial diameter as a DWI lesion, where you have a combination of vasogenic and cytotoxic edema. And then some of these lenticular striates seem to perfuse just a larger territory than usual, right? So I think it is possible to see, there'll be like a pedicle and it'll branch into a few branches. And if the very proximal portion's occluded, I think you can get a greater than 20 millimeter, even maybe a 25 millimeter or so, sized infarction from a lacunar. The other thing you can see that would be on the differential, sometimes if you have occlusion of a long course of the MCA by an embolus, um, that subsequently recanalizes, you can block multiple perforators from that embolus, and you can get like kind of like a large area of corona radiata infarction. And if the embolus resolves before you do your vascular imaging, it can be a little confusing because now the MCA is open, but you've got these multiple lacunes infarcted. So that's my differential for the larger size lacunar type lesions.
Thank you.
And then next question is, are there any studies showing correlations with hypercoagulable states and an increased risk for lacunar strokes?
Yeah, it's an interesting question. I don't really know of too much. I didn't come across it in some literature searching to update the results of this talk. So other than I guess I did note that Mendelian randomization studies of genetic epidemiology did point to hyperhomocysteinemia, right, as a factor, and that there's obviously treatment of hyperhomocysteinemia, screening and treating homocysteine to prevent stroke has been kind of a controversial topic with neutral results from VitaTops, but positive results from some Chinese trials where there's less folate supplementation and generally higher homocysteine levels. I'm not aware of associations like specifically about like with anticardiolipin antibody or other antiphospholipid antibody syndromes or so forth. Although I think you could get, I don't see why you couldn't get infarction in small vessels. Although I'm not sure that lacunar stroke needs to prompt you to look for these hypercoagulable states unless you have other clues like recurrent strokes or unusual patterns of infarction with multiple simultaneous, multiple infarcts.
And then Dr. Sidoroff in Oklahoma, he was asking about the anterior choroidal strokes, given that, between large and small artery, these are bigger.
Yeah, I don't know. I mean, I think they're mostly not included when people are talking about, like deriving inclusion criteria for a cohort study, prospectively or retrospectively. I think as you're hinting at, I don't think of them as small vessels, but not big vessels either. I guess it's a medium vessel kind of phenomenon, and it's a rare stroke syndrome, but often puzzles, can puzzle you if you're not keeping it in mind, particularly, and for trainees that maybe haven't seen it too, right? Because you can have a patient with a pretty big deficit, mimicking, an MCA territory stroke, right? Because they've got, hemiplegia and hemianopia and cortical signs from maybe even some thalamic involvement, this kind of thing. And but it turns out it's an anterior choroidal. So yeah, and then in my experience, most of these have been a clue, like a top of the carotid embolus is more often where we've seen it rather than like rather than infarction of the anterocoroidal artery itself, although it can happen.
And then let's see, we've got a question about, so if you do raise blood pressure, for somebody with lacunar strokes, if you're experiencing them with neurological deterioration, how long do you typically do permissive hypertension?
Yeah, and I think in the past I've tried also inducing hypertension, although after causing some heart failure and like troponin leaks and MIs, I'm sort of reluctant to do that, particularly in older populations. But yeah, I didn't talk about the timing, so I didn't put that on the slide, but I should have addressed that. So most studies would suggest that if patients are going to fluctuate back and forth between milder and more severe deficits, it's going to happen within 72 hours, usually after the first symptoms, although some studies describe rare recurrences up to a week. So I think once you're at 72 hours, you're like out of the risk period, and most of the fluctuations even occur within 48 hours. So I think leaving permissive hypertension for 72 hours and then trying to, judiciously bring it down. Like I don't think you have to rush to bring it down then either, right? You can start low doses of oral agents and then titrate, but 72 hours would be a good time frame when you can start controlling hypertension, which is necessary in the long run, and also when you can think you might be leaving the risk period.
There is a question from Farzan.
Yeah, hey, can you guys hear me okay?
Yes.
Yeah, I hear you.
Two quick questions. One, do we know what tips these patients over the edge? I mean, this is an ongoing chronic process. You would think that you would see some symptoms. Obviously, the capsular warning syndrome is there, but what tips them over the edge other than knowing that the arthromatous disease is there and blocks off the artery? Is there some other mechanism that we know about? I probably not. I assume because we didn't mention it. And then the other question is, have we looked at the choice of the antihypertensive calcium channel blockers versus something else to see if we can reduce the risk of any kind of progression in symptoms or anything like that?
Yeah, interesting questions that I don't think we know the answer to either of them. With regard to the former, yeah, there's been a lot of focus on like modulating the thrombosis pathways, right? So this has been the main thing that's been trialed, and I think there's pretty good evidence that acute lacunar strokes are caused by thrombosis of a small artery. One wonders whether other factors might be at play, particularly because you see like you get a sense there's a higher frequency of deterioration or deterioration improvement despite being on guideline-based, antiplatelet therapy. Like it just happens more often, right, than with large artery athero or other things. So you wonder whether things are going on other than the thrombosis. What could these other things be? People have hypothesized that blood-brain barrier leakage, might play a role. There are some of the things in the plasma, like, thrombin, ferritin, these kind of things have some toxic effects on the neuropil, on astrocytes and neurons. There may be some aspect of like electrical disturbance too. Could you be doing something to, I don't know, myelin function or transmission of electrical impulses along the axons? Could these are usually affecting white matter tracts, right? Is there something about, could you be electrically silencing activity along these white matter tracts? This is very speculative though, because we don't really have the research tools to study this well in vivo. I think we have some studies with 7T MRI that have tended to look at someone with a lacoon and like look at and have found, that there are irregularities, different morphological changes in lenticular striates, including just like more likely to have cutoffs in them, like that example that I showed you. What we need though is like somebody to be sticking the person in and out of the magnet each time they fluctuate though, right? Like usually it's a one-time 7T image. What we need is like an image, okay, well, here's someone with the lacoon and an NHF 14, and here's the image at 7T. Then they, NIH improved to 2. Here's the follow-up 7T image, like is because the artery canalized or not. They got worse again. Here's another 7T of that same artery, but we don't have like serial imaging of these arteries yet, to my knowledge, or like very limited, that would tell us whether everything is due to, recanalization and reocclusion. I mean, these are tiny arteries, so you need less fibrin and platelet buildup to reocclude them than a larger artery. So maybe it is just, the issue of reocclusion. But yeah, one wonders whether there's aspects of the pathophysiology that are lacking. And then your second question was like which antihypertensive drugs may be best at preventing lacunar disease. I'm not sure that we know. If you know of any data, well, you probably don't because otherwise you wouldn't have asked the question. But if you know of some data, please share it with me because I'm not sure that I know. Obviously, in general, we prefer using calcium channel blockers like amlodipine and ACE and ARB. Have better evidence than beta blockers. And interestingly, there's maybe some suggestion from that LACI-2 trial that isosorbate mononitrate, might be an effective antihypertensive agent, although these data need to be confirmed in the phase 3 trial, which they're working on starting. So other than that, though, I'm not sure that I can give you any specific advice about different antihypertensives. This is where I'm hoping that things like Mendelian randomization, which if you can predict like sort of pathways that are more active in different people that are modulated by different drugs, this can help you give clues as to which pharmacological strategies to choose. But I don't think there's any. I'm not aware of any specific studies that have pointed to optimal treatment of lacunar disease yet.
Got it. Thank you very much.
Thanks.
And then Vishnu, our colleague up at the Woodlands Hospital, he had another question about, how long do you wait to say that the person's no longer at risk for deterioration?
Yeah. I think it's that 72-hour mark. It's not impossible, but at that point it's unlikely. And in the last 24 hours of that period, the risk is declining. In the first 48 hours, it's a little hard to know. And of course, I don't want to give the idea that every patient with a lacunar is going to get worse and da 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 da. But 10 to 20% of them do, right? And I showed a bunch of risk factors, but no one's tried to use those risk factors to say, can we accurately predict who's at risk, right? They're more saying, okay, well, the odds ratio for getting worse is this or that or the other thing. So we know these factors are related. But in my experience, it's not a very predictable phenomenon, which is kind of like a bit problematic. So what does that mean for clinical practice? I guess it might push me a little bit, well, maybe the main predictor though might be if they've already fluctuated and you're within a short time window, then they are at high risk. I didn't mention that specifically, but that is the case, right? So if I'm admitting someone with lacunar stroke with like stable deficits, I'm less worried about that than a lacunar stroke where it's been preceded by a TIA within 48 hours, or where their neurological symptoms have fluctuated. I'm going to be more aggressive if they have fluctuating symptoms, right? I don't give thrombolysis to patients with non-disabling deficits, but I might push the envelope a little bit, right? If it's one of these patients that has had a fluctuation with like a higher deficit from a lacunar lesion in the past and is now improved with like kind of a moderate deficit, that'd be a factor that pushes me to give thrombolysis. I think I might choose aspirin and ticagrelor, at least for that 72-hour period, rather than aspirin and clopidogrel. Just in case they're a slow metabolizer, and based on that analysis from the Chance 2 trial. So hopefully that's helpful. I might keep them a day or two, right, too, as opposed to, well, their deficit's mild and they could go home, if they had a recent TIA within the last 24 to 48 hours and have new lacunar syndrome, I might be tempted to keep them at least 24 to 48 hours too, right, in case deterioration happens in hospital. So these are the ways that I change my practice to accommodate this knowledge.
At our center, we've tried so many different things.
Yeah, what do you do? This is what I was hoping to learn. Yeah.
And then we published different papers. I think it's kind of interesting. When I came here, 2B3A inhibitors were being looked at, and I think we kind of not really knowing, not having a comparison or a control group. We hit a reset and said, it might be better for us to try to better understand, the natural history here. With our standard of care approaches of head down and blood pressure management, fluid and so forth. And, we published a nice paper in 90 patients looking at, what we found as predictors of deterioration, and intriguingly found that those that got TPA turned out to be a risk. And so we wondered about that. Does that speak to the pathophysiology of what you said about a reocclusion? Could this be thrombosis, rethrombosis, phenomenon? But that 72 hours is what panned out, just like you said, in terms of, when that vulnerable window. But I have to say, we never really found anything that I think materially had an impact to change the rate of deterioration, whether it was heparinoids, fluids, 2B3A inhibitors, clopidogrel loads. In this time period, we didn't have ticagrelor. But Jim Grotta was always interested in putting them in a hyperbaric chamber, and and seeing whether that might have an effect or not. He said he had a couple of cases where he had done that and they got better, but it was never put into a trial because we had access to be able to put patients in hyperbaric chambers in that time period.
Yeah, we've tried everything too. And your experience with the 2B3 inhibitors was really important. We don't use as much of that, more for kind of logistical reasons. At Foothills Hospital, it's kind of a pain. They would have to go to an ICU where we don't control the beds, and so it just logistically was difficult. But that was important. But yeah, the first time you try any new thing, it seems like, oh, maybe it worked. And like it just seems, but then over and over as we gain more experience, it was difficult to distinguish anything from the natural history. The hyperbaric chamber is interesting. When I was at Mass General, 15 years ago, there was a hyperbaric chamber at the Mass Eye and Ear Infirmary because they had a plastics ward there and they were using it for like wound healing. So we talked about different scenarios to like pilot putting some stroke patients in there. Anish Singhal and Mark Fisher at the time also working on hyperoxia at like normal pressure as well, right? As exploring that as a treatment in the ambulance. With some concerns that maybe the oxygen-free radicals and stuff might, that hyperoxia or, might have some potential adverse effects too, right? But so that was bandied about a little bit, yeah. But we never actually took action on it either in the end. So, yeah.
I was hoping 7T would give us some answers to the pathophysiology. I guess it sounds like it hasn't entirely gotten there yet, and I was hoping the resolution would be good enough to be able to see if there's, in these situations, whether there's an acute occlusion, acute thrombus, or something, that could be seen. But I guess we have to wait for a higher strength.
Yeah, you start getting some patient symptoms at 7T. It starts like tickling some of the calcium ions in your otolith and other stuff, and so it may be, but there's always the possibility of further development of post-processing techniques. There's a lot of use of AI on images now to try to refine and kind of sharpen pictures. And I think part of what needs to be done is just more serial imaging, right? Like you see lenticular, it looks windy or it looks like it's thin or something. What did it look like 10 years ago, right? Am I just looking at a chronic thing, or is this something that had changed acutely when the patient had a stroke syndrome? And what about the patient's outcome? So I think I'm a little disappointed it hasn't moved faster. We don't have a 7T scanner, so there's nothing, I can't contribute to this in any way. Maybe it's just more difficult to get access to the scanner and do repeat imaging in this patient population. But I think a simple thing, although will take some work, we'll be doing serial imaging, right, to understand how dynamic the changes they're seeing will be. That might lead to some insights.
Yeah, I'd love to, with the perfusion imaging as well. I mean, see whether the zone of hyperperfusion is increasing, around the lacunar.
Exactly. Yeah.
Yeah. Any other questions that people have? This has been great. I mean, we're way over and lots of people still here. Eric, thank you so much. I think this has been fantastic. We really appreciate your time here.
Thanks, Sean. Thanks for having me. Have a good rest of the day.
Thank you. You too.
Thanks.
You too.
Bye-bye.
Take care.